Oh, yeah. Yeah, we've been.
Well, it's noon, and I think we'll go ahead and get started. Good afternoon, everyone. Welcome to the 33rd Annual Take Wing Lecture. I'm Mary Ann Jackson, Dean of the School of Medicine, and I'm proud to be here with you today. The E. Gray Dimond, MD, Take Wing Award is the School of Medicine's annual honor given to a graduate who has demonstrated excellence in his or her chosen field and exceeded the expectation of peers in the practice of medicine, academic medicine, or research. The first Take Wing Award was presented in 1988 to Dr. David Hayes, and this year we are proud to honor Dr. Mario Castro as we recognize his accomplishments in the field of pulmonary and critical medicine and the major roles he has played leading several initiatives to combat the COVID-19 pandemic, including leading the NIH co-VPN vaccine trial and the ACTIV-2 drug trial. Dr. Castro, a 1988 graduate of the School of Medicine, did his residency in internal medicine at the Mayo Clinic, followed by a fellowship in pulmonary disease. He received an M.P.H. from the St. Louis University Graduate School before spending his first 25 years practicing medicine at Washington University, and then this past year coming back to the University of Kansas. He is a professor of medicine and director of the Frontiers Clinical and Translational Science Institute, a recognized national leader participating in the CDC's Controlling Asthma in American Cities, in the American Lung Association Airway Clinical Research Centers, and as a member of the National Heart, Lung, and Blood Institute Asthma Clinical Research Network, Severe Asthma Research Program, AsthmaNet, and Precise Research Networks. He's clearly established himself as a nationally recognized expert. An author of over 30 chapters, books, and over 300 peer-reviewed articles over the past 25 years plus, Dr. Castro has trained over 40 junior clinical and translational scholars. He's widely recognized as an expert clinician, an excellent mentor, and skilled educator with significant commitment to the development of young investigators' careers. In his Take Wing remarks at graduation on Saturday, Dr. Castro commended all members of the healthcare team who met the challenges of providing care for patients during the COVID-19 pandemic. He reflected that as he started residency, he felt confident in the preparation he received at the School of Medicine, and he shared 3 thoughts with the graduates that I want to share with you here today. He emphasized the importance of faith in oneself and in sharing one's own personal faith as a means to serve our patients and be more approachable to them. He also emphasized that physicians stay inquisitive and question dogma to enhance care of patients, and that we always pursue our passion on our journey to become the best member of the healthcare team that any of us can be. Today, he's going to speak on the care of patients with severe asthma, which has been the major focus of his research in his career. Thank you for being with us, Dr. Castro, and we welcome you to the podium.
Thank you, Dean Jackson, and it's been many years since I've been in this same Theater A as a student, and it's just wonderful coming back to the school and seeing all familiar faces and being part of UMKC once again. I wanted to focus today a little bit on what my research has been, and I'm going to start with a patient here. This is a patient I took care of with severe asthma, and part of our focus has been how do you utilize imaging techniques like CT scanning, as in this image, to do a 3D reconstruction and to understand the process of airway remodeling. And so I'll come back to this patient a little bit later, but I wanted to reflect just a little bit first on where I started, and my mother, Margot Julia Castro, is here with me today. And this is where we started. In 1965, we left Matanzas, Cuba, which on this map here, you can see that's where we started, very humble setting. My father was a baker, and my mother was a teacher. And we left straight from Cuba to Mexico City, obtained our visa, and came here to Kansas City. And so this is actually was published in the Kansas City Star when we came here. I love looking at some of these quotes. Life in Cuba today is almost impossible. It is more of a bleak existence than anything else because of the system under which the country lives. And here my mother is referred to, has her PhD, Margaret Julia Castro, his wife, doctorate in teaching, and she continued teaching here in Kansas City at Westport High, actually taught Spanish here in Kansas City many years ago. So we started there, and as we got a little bit older, you can see, as my friends often say, I was a little nerdy, you can see. These are with me, my brothers. You know, we were really cool with our jackets back then. That was the style. And then certainly as my life started to mold here, I became an Eagle Scout here in Kansas City and attended Rockhurst High, and it was really instrumental to my future career. This is my wonderful family now. My two children, Darian and Victor, are part of are here today with Olivia Castro, Darian's wife, and Ellen Greiner, future wife of Victor Castro. And we've enjoyed as a family being together. And my wife, Marianne Castro, is here. We've been married now 33 years, I'm sorry. and 3 wonderful children. And certainly, as those humble beginnings shared with you at the beginning, coming here from Cuba, we really call Kansas City our home. And it's so wonderful to be back. So with that background, I want to talk a little bit about some of our insights that we've made into severe asthma. First talking about the pathophysiology, what drives it, and then talk a little bit about treatments that we've been involved with. So this is one of my first fellows, published in 2007. We did research bronchoscopy. We obtained biopsies for my patients. And on the far right here, you'll see a patient with severe asthma, and their airway epithelial cells, you can see, are markedly abnormal in comparison to a normal individual. Nicely pseudostratified epithelium with cilia here. You can see that it's thicker in the patients with severe asthma and filled with these clear spaces, which are goblet cells. And we'll talk a little bit more about that. But we made these observations, which were novel observations at that time, that the epithelium was leading to thickening of the airways in our patients. We subsequently have focused on the production of mucin proteins in those epithelial cells. So this immunostaining here for MUC5AC, which is one of the most common mucin proteins produced in our airways, you can see is highly expressed in a patient with severe asthma in comparison to a mild individual or normal individual. So our lab has been working on what's driving that. What's the mechanism behind driving that mucin expression? And so you can see here, one of the things that we've looked at carefully is the evolution of these basal cells to clara cells, mucus cells, and the role of this intermediate ciliated cell, which also can become a ciliated mucus cell. And we know that one of the key drivers of that pathway is IL-13. So we've tested this hypothesis now over a number of years that if you could inhibit apoptosis of the epithelial cells in this EGF-dependent mechanism, then perhaps you could interrupt that IL-13-driven disease in the airway epithelium. The way we've approached that is just like we did some of our earlier studies. We obtained airway biopsies and brushings from the lower airways. I've been fortunate our patients have contributed now over 600 patients. We've done research bronchoscopy in, and it's allowed us then to study each one of these cell types and these different mechanisms that may be driving that IL-13 mechanisms. And some of our findings that we're currently working in our lab is the role of these ciliated cells. So we quantify that, and what we noticed in comparison to healthy individuals, asthmatics have less ciliated cells, which you can imagine is not healthy. And that is also seen within asthmatics. The severe asthmatics have less ciliated cells, even within the asthmatic group here. And so this is characteristic of asthma pathology, is you start to lose these ciliated cells, and we want then to understand how does that relate to the mucus accumulation that occurs in the airways. So this is immunofluorescence of the airway cells. The top panel is here from healthy individual, and the bottom panel here is from one of our severe asthmatic patients. And you can see here that there is mucus present even in a normal individual, but at greater expression levels within a severe individual. However, the ciliated cells almost completely disappear. In fact, you can only see this under the microscope, just a few of those ciliated cells. This is one of the markers of cilia, FOXJ1. And you can overlay this here on the far right, and you can see, again, loss of these ciliated cells and marked upregulation of mucin expression in the airway. We also quantified that mucin expression. Here you can see in asthmatics, and then within asthmatics, even the severe or much greater increased production of that mucin protein, which is primarily MUC5A protein. And you can see this again in a severe asthmatic, and you can see these goblet cells kind of throughout the airway epithelium here in this biopsy. So we believe that this mucin is part of the severity. And so what we've also looked at is inflammatory markers to characterize that. So one of the things that allows us to do this less invasively is to do a sputum induction. And with that sputum, then we can analyze it in the lab. One of the things we do is a differential. And you can see here, interestingly, as you have greater number of eosinophils in the sputum, the greater the mucin intensity. And then vice versa, also the less neutrophils you actually have, you start to see a decrease in mucin expression here. And you can see that this is a significant inverse relationship here, which is highly significant, even in this relatively small sample. So when we look at these categories, one of the things we know in asthma is eosinophils drive the disease process, and there's a high level of expression of mucin in the airways. There is a decrease in those ciliated cells, positive cells in the airway epithelium. Whereas on the other side, when you have less eosinophils and more neutrophils, you actually have less mucin expression and more cilia. So almost more of a healthy type of picture. So we believe that this mucin expression, and we'll talk a little bit more about that, is directly correlated with eosinophilic inflammation and inversely correlated with neutrophilic inflammation. And this is certainly is going to lead us to our next topic, which is how do we treat some of these patients with a personalized approach when we start treating with biologic therapy and aiming towards T2 disease. Before I jump to that, I just want to mention one other part that our lab has been working on, which is like that first patient I showed with severe asthma. We take our patients through just a regular CT scan. All of our modern CT scanners are volumetric scanners. You can basically do one of the latest CT scanners in a single breath. You capture in the entire CT. What we've been trying to do is advance the field and try to get away from just going to the radiologist and depending on their visual interpretation, qualitative interpretation, to a much more quantitative interpretation. And so this is using software that we've been working with a group in Iowa called VITA. And this is based on our severe asthma research program. The top panel here, you can see you can do a 3D reconstruction of the airway, and you can actually model this just like we see through the bronchoscope, but using a CT scan. And this also not only allows us to look at the airways, but also the lung parenchyma. So it gives us structure in terms of the airway, but also the lung parenchyma. And then also talk about subsequently, we can study function of the lung in a much more detailed quantitative fashion than we currently at this point. Ravi Isola was one of my other fellows who's currently practicing at MD Anderson. And Ravi in our lab was actually trying to match what we're measuring by the CT scanner together with the biopsies, the histology that I just showed you. So this we published a few years ago in Chest. In the top panels is a normal individual. In the bottom panel is somebody with severe asthma. And what you can tell is that, again, nicely ciliated pseudostratified epithelium here with that cilia. And this is that same patient's CT scan. So you can see normal wall thickness here. Whereas this severe asthmatic patient on the bottom right, very angry airway epithelium filled with those mucin cells. And you can see the airway wall thickness is markedly increased in this patient. Therefore, we think CT scan will allow us to measure remodeling of the airways in a way that we have not used to date. And so this is some of the data from that same study showing that there was a correlation between the thickness of the CT scan right here and the wall area from that CT scan with the epithelial thickness that we measured in the histology. And that also had a weaker correlation with the subepithelial thickening or the lamina reticularis. And then importantly, this was inversely correlated with lung function. So the thicker the airways that you saw on the CT scanner, the lower the lung function that occurred in those patients as reflected by the FEV1% predicted, and had a positive correlation with response to bronchodilator. So one of the latest studies that we published in JCI a couple years ago, this is led by Eleanor Dunnican, who was at UCSF at that point, but now is in Ireland. In this study, we took a panel of 5 different chest radiologists across the US, and they went through each segment in the CT scanner and followed it, each of those airways all the way out into the distal bronchioles. And what they did was they quantified each segment as having a mucus plug, as having a score of 1. And so there's 10 on the right, 10 on the left, and so you could have a score from 0 to 20. And so you can see this patient here has a plug in this segment here, whereas this segment here has no plug in that potential airway. And when we looked at patients over time, the patients that maintain these plugs over time, or if they don't have plugs, they maintain that over time. And that's important because, as we'll talk about next, we were then able to relate that to lung function. So if you had a high mucus score, having a score of 1 to 4 would put you in this low category. 4 or greater would put you in that high mucus score category. And you can see what happens to lung function. Markedly decreased if you have a lot of mucus plugs. So on average in the mid-50s here. So what's driving that process? Well, getting back to that eosinophilic inflammation in the sputum, you can see the sputum from these patients with high mucus plugs have a very high sputum eosinophil level, almost 10 times what we would expect normal. And then if you look at the mucus plugs again, over time, those that don't have mucus plugs, sometimes they form them, but sometimes they just persist not having mucus plugs, whereas patients that have mucus plugs at the beginning, at baseline, on follow-up, some of them develop mucus plugs over time. So the key here would be if we can measure this, perhaps we can intervene with treatment, with a modality to treat. So as I talk about treatment that we've been working on over the last 20 years, really what's allowed us to move the field forward beyond inhaled steroids is to characterize patients by their subtypes. And we call those phenotypes. So we've initially did a cluster approach of our severe asthma patients in our severe asthma research program, and we identified 5 different clusters. And then we tied those together with these biomarkers. So the idea is that in the clinic, you can measure these biomarkers, and then you could identify a particular phenotype. And perhaps that would help us advance the field forward. Unfortunately, genotype has not been very helpful in this common chronic disease. The allele frequency of these rare variants is quite rare, so we really haven't been able to using genotyping to advance the field. But the idea is that now that we understand these phenotypes better and we have these biomarkers available, perhaps then we could tailor therapy that would be very specific to that patient's treatment. So these are the biomarkers that are currently available in the clinic, and so allergists, pulmonologists, physicians can use this in our practice in these patients with severe asthma. All of us have been very familiar with the story behind IgE and its relationship to allergic disease or atopic disease. And what we've learned, though, is it really only does that. It helps you identify atopic or allergic disease, but it doesn't help you in terms of selecting biologic therapy. It doesn't really correlate well with asthma severity. And so what we have advanced the field, though, is the use of blood eosinophils. So a simple CBC with diff, you just take a look at the absolute eosinophil count. And if it's greater than 150, that identifies a potentially medium driven disease in terms of T2 levels, and certainly greater than 400 is a highly eosinophilic patient. A lot of us in research areas have sputum eosinophils available, but it's not very practical for the clinic. And so the last biomarker that we have is relatively new in the last decade, called FeNO, or exhaled nitric oxide. So this is basically, you can have a patient blow into an analyzer, which can be available in the clinic setting, and you measure in parts per billion exhaled nitric oxide levels, which reflect airway inflammation. And in general, we're using a cutoff of greater than 25 parts per billion to identify T2 disease. So in essence, we now have two biomarkers that we can use in the clinic to decide therapy. And then this is a schematic of the underlying pathophysiology of asthma that we talked about earlier in terms of the airway epithelium, those goblet cells, the hypertrophy, the smooth muscle, the thickening of that basement membrane, as well as this hypercontractility of the smooth muscle surrounding that airway. And so we now have all these boxes in red are therapies that we have available in the clinic. These are biologic therapies that we have, and I'll talk more about those and our role in terms of using those therapies, again, in our patients that have been phenotyped. The ones in green are currently not available, but are undergoing studies that we've been involved with. The latest one, this one molecule is an alarmin that's released by the airway epithelium, TSLP. And this molecule, this biologic therapy, will likely be available later this year. It's undergoing review by the FDA now. So these are the 5 biologic therapies I use in my patients now. The anti-IgE has been around now for almost 20 years. It's really helped us, and I won't have a chance to go through each one of these in detail, but I will talk about dupilumab at the very end. There are 3 anti-IL-5s that are available for our use in the clinic. The only difference between these 3 is benralizumab binds with the receptor and induces apoptosis of the eosinophils. Again, those cells that we talked about earlier that are key in terms of that eosinophilic inflammation. And the FDA has now already approved those in bold in addition to asthma. So you can treat a patient with omalizumab for their allergic asthma, but you can also treat them for their urticaria. Chronic urticaria is another FDA-approved indication. Mepolizumab, approved for both EGPA as well as hypereosinophilic syndrome, and dupilumab, also approved for atopic dermatitis and rhinosinusitis with nasal polyps. But you can see that there are a lot of other T2-driven diseases that we're studying, whether or not these biologics will be effective in those other indications as well. So I know this is hard to read, but I'm going to go through this in a little bit more detail a little bit later. But this was just published last year in the GINA guidelines, which is the global initiative for asthma. So it's international guidelines that we follow across the world as well as here in the US. But this schematic, I'll go through in a little bit more detail, but it allows us then to understand how to use those biomarkers in the clinic. So first, I just want to talk about the last one that we talked about at the, in that table of 5 different biologics available, called dupilumab or Dupixent. Dupilumab is an IL-4 receptor blocker, so it blocks 2 of the T2 cytokines, both IL-4 and 13. With one biologic therapy. And so we published this a couple years ago, showing that if you use dupilumab in patients with T2-driven disease, they had to have, we treated all patients and all comers, and I'll show you the details in those that are eosinophilic and those that have high FeNO signature. But you can see overall in the intent to treat population, there was about a 50% reduction in exacerbations. This was accompanied by improvement in lung function. So this was a major advance because the biologic we had been using for a number of years, omalizumab, only reduced exacerbations but did not improve lung function. So that was kind of always something that held us back in the field. And as noted here at the bottom, also demonstrated improvement in quality of life and asthma control. And this is the improvement in the lung function that we demonstrated in the QUEST study with dupilumab. You can see even after 1 injection, at week 2, the FEV1 improved by almost 300 mLs, which is remarkable. And this was sustained over an entire year. And so now we have a biologic therapy that will not only reduce exacerbations, but also improve lung function. Well, what about those biomarkers? So on the far right graph is the intent to treat population, and you can see the eosinophil cutoffs here. So what we learned was that if you have eosinophils of 150 or greater, or 300 or greater, you have a greater efficacy. And it's because the eosinophils are a marker of T2 inflammation. It's a surrogate marker of T2 inflammation. The other biomarker that I mentioned you have available in the clinic is XL nitric oxide, or FeNO. And FeNO also allows us to select patients that are going to much more likely to have a response to dupilumab. You can see here using a cutoff of 25 parts per billion or 50 parts per billion, a marked reduction in exacerbations. So, and we can do FeNO even in a young kid down to age 6. It's basically you just breathe out for 10 seconds and you can measure it in the clinic. So that diagram that I mentioned earlier from the GINA guidelines, basically it now advocates that we use these biomarkers to identify type 2 inflammation, so using that blood EO cutoff of 150 or greater, FeNO 20 parts per billion. They used a little bit lower cutoff than we did in the QUEST study. If you have sputum eosinophils available, you can use that, or if it's allergic driven. And so if it's allergic driven, if you have really high, a good history from your patient that they have these seasonal triggers, and especially in children, we see this kind of seasonal driven asthma. You can use something like omalizumab if you meet the criteria for omalizumab based on the serum IgE and weight, and they've had exacerbations in the year. And these are some of the biomarkers that, in one retrospective study, demonstrated that you might have an enhanced response to omalizumab. Unfortunately, IgE levels do not predict response, and that's something, kind of a misconception that sometimes my students or even residents have, is that you only use omalizumab if the IgE level is high, and that's not true. You can actually use it in a setting of a severe allergic asthmatic that has a normal IgE level of even as low as 40. Now, eosinophilic-driven, anti-eosinophilic therapy with anti-IL-5, you identify that again with that blood eosinophil level of 300 or greater. And again, that blood eosinophil predicts response. The higher the blood eosinophil level, the more likely your patient is going to respond to an anti-IL-5. The exacerbations also predict that. And an interesting nasal polyposis in adult onset disease. So I always ask my patients, when did asthma start for you? And that's been a very helpful characteristic. Whereas you can see here with allergic-driven disease, childhood onset asthma has a closer link to allergic disease. And then the bottom here is the third class of biologics we have available, dupilumab being the first one in that class. And again, having either blood eosinophils or FeNO can be a predictor of response, as demonstrated here, but you can also use it to treat atopic dermatitis as well as nasal polyposis because it has that indication. So a patient I saw this past week in the hospital, he had severe asthma, elevated eosinophil levels, but his sinuses were just packed with nasal polyps. He had an asthma for a number of years, and we'll be starting him on Dupixent because of the indication that he has, both from his severe uncontrolled asthma as well as his atopic dermatitis. Well, I just want to venture a little bit away from biologic therapy and something else that we've worked very carefully on, which is bronchial thermoplasty. And I mentioned this at the commencement address. This was one of the things I had to fight dogma because I was told applying heat to the airway is a bad thing. And so we tested this first in dogs, and then we moved on kind of our early phase studies that allowed us to understand whether or not this would be helpful. And we use the bronchoscope to get into the lower airways, and we use this catheter that has these 4 contact points to deliver the energy from this radio frequency controller device. And basically that energy delivers 65 degrees Celsius for 10 seconds, and we do a series of activations in the lower airway. The convention, and I'll talk a little bit of how we're fighting that dogma, but how is FDA approved is you do 3 treatments. You do the right lower lobe, wait 3 weeks, do the left lower lobe, wait 3 weeks, and then do the upper lobes in the last treatment. And this was the first study we published, a randomized sham-controlled trial in 2010, showing that bronchial thermoplasty decreased exacerbations by 32%, unscheduled office visits, ED visits, here you can see 84%, and hospitalizations by about 73%, showing that this does work in terms of reducing exacerbations. There is a little bit of a trade-off because patients, when we apply the heat, often it will trigger a mild exacerbation. And so we tell them to expect that after each treatment. We treat it with bronchodilators and steroids, and they recover within a week. But it is a little bit of a trade-off, and so we make sure that they're aware of that. But the key here is that we now have followed these patients for over 5 years. So this we published a few years ago, showing that reduction in exacerbations is maintained over time. There's no rebound phenomena, there's no recurrence of those exacerbations over time, and patients maintain this reduction in exacerbation over 5 years by around 44%. Now, one of the things we're challenging, though, with bronchial thermoplasty is perhaps we are not having to do all 3 treatments. Perhaps we could do targeted therapy. So one of the things that Chase Hall, one of my fellows that worked with me at WashU, who's now at KU with me, is perhaps you could use hyperpolarized xenon gas MRI to identify areas of the lung that needs to be treated. And so this is a normal individual that inhales xenon gas. We polarize it with a polarizer first, so you can excite the molecule and you can actually see it on MRI. So you do a simple proton scan of the lungs, which looks black, but when you inhale the gas, you can see it goes all the way out into the periphery here in this normal individual. Well, what happens in severe asthmatics is they have huge defects, ventilation defects. So you can see this whole area of the lung is not being ventilated at all. In my patient with severe asthma, you can see there's multiple defects. On average, our severe asthmatics have about a 30% ventilation defect. So what we did was perhaps we could use that to guide where to use bronchial thermoplasty, and perhaps we could only have to do 1 treatment. And so we just published this this year, in fact, a pilot study in 30 patients. Half received targeted therapy, half received conventional therapy. And so with targeted therapy, what we aimed for was that ventilation defect here. And you can see what happens after bronchial thermoplasty. This same patient now has adequate ventilation, not completely normal, but improved ventilation to that area. And you can see, again, this is the segment that was treated in this targeted patient.
And then we treated these other areas of the lung. And you can see there's a huge defect up here. Now look at the same patient after bronchial thermoplasty. So we are using this technology to guide where to treat our patients with severe asthma. And this is the results in all 30 patients, showing that if you look at quality of life, which was the primary endpoint in this particular study, that there was an improvement from baseline both in the guided group and the 15 patients that were guided and the 15 patients that were unguided that received conventional treatment. They improved after bronchial thermoplasty number 1 in the guided group. And you can see here, this was really no different than the group that received all 3 treatments. We ended up, because this was a pilot study, having to treat everybody all 3 times. And so even the guided group went ahead and had 3 thermoplasties because that's what they were approved for. And so we felt that we had to give it to them, at least in this pilot study. But what we were very intrigued by that this improvement in quality of life with just 1 treatment gave you the same result as 3 treatments, and the number of exacerbations was markedly reduced by less than 40% of these patients that got conventional treatment. So just to finish, what I think is an exciting field is that asthma now has these biologic treatments that are available for our patients. Allows us with broad application of the biomarkers to target our patients in a precise precision medicine-driven approach with an adequate safety profile. The key here being blood eosinophil levels and exacerbation history predict response to these 4 biologics. Nasal polyps, oral steroid use, and lung function also predict response. The biologics for T2 asthma vary by their mechanism and dosing. So for example, if you're going to use omalizumab, anti-IgE, it's going to target that IgE and the receptors on mast cells and basophils. Whereas dupilumab, which is that IL-4 receptor blocker, can be used every 2 weeks. These are used every 4 weeks. And then benralizumab can actually be used every 2 months, which is nice. So you only have to give yourself an injection 6 times over a year with benralizumab. These are all available in the sub-Q route. And then as I mentioned with dupilumab, you can also treat your patients' rhinosinusitis as well as their eczema. And then lastly, I keep bronchial thermoplasty in my pocket for those patients that really are not eligible for a biologic or are not responding to their biologic therapy. And so we get a number of referrals for these patients that our colleagues in the community have treated with biologic therapy and they're not responding. I just want to jump a little ship to end with kind of some of the things that have driven me just recently in the last year and a half while I've been here. And that's our focus on respiratory health and in general. And I want to start off with a little story about work that we've done in Central America. This is actually a picture from southern India that we were doing a project on cooking stove technology. And we, in that project, went to India, measured lung function in about 120 villages and in women and the children that lived in the house with them. And we used, in half the house, we modified the cooking stove, and the other half, it was conventional cooking. And that's to be published, but it was a wonderful adventure. One of my sons, Benjamin, got to go with me on that trip. But what we've also been working on in Central America, and Dr. Jeff Matthews goes with me, that's here today, to Honduras, and we call it the Breathe Brigade. This was a mission that we started almost 20 years ago with various specialists from around the country. Of course, we focused on pulmonary, but other teams emanated from that. Otolaryngology had 3 teams going to Honduras, and we also have now added a number of other teams in cardiology, gastroenterology, neurology, orthopedics, and GYN surgery as well. And so these are just some of the pictures. This is the area that we travel to once a year. We were very fortunate last year. We went in February. This is a picture of us, our team down in Honduras in February, right before the pandemic broke out. As you can imagine, we weren't traveling after that. But these are the various teams that are here. You can see Victor Castro there helping us unpack the medications. As you can imagine, the medications is one of our highest hurdles. You can see here also we had surgery doing that. We actually built this hospital together with the Catholic Church. We were able to raise $3 million, and the Honduran government put in another $3 million, matched that donation, and we built this hospital. And we fly our specialty teams down there to provide specialty care. There are over 150 employees within that hospital, and we work with the primary care practice that they have there. So we're not trying to do primary care. We just fly in these specialty teams because they have no access otherwise to neurology, orthopedics, or these other services. These patients would have to go to the capital in Tegucigalpa, which a lot of them could not afford, or they would not have access to specialty care. So this has been really a wonderful addition to our takes us away a little bit from the modern practice of medicine, but it allows us, I think, to think about other conditions in healthcare outside of the U.S. Just like to end with a little story. We were took away this past year and a half and focused all of our efforts on COVID. And in March, when this broke out, I was approached by one of my colleagues at Children's Mercy, Barbara Pahoud, to work together on a vaccine trial. And so I'll talk about that in a second, but I just want to say that there is a huge need for us as healthcare providers to get that message out in the world in terms of vaccines. This I just downloaded this morning from the New York Times website. We are currently at 1.5 billion doses of vaccines administered. Here's the data for the U.S. You can see fully vaccinated. We are at 37%, and at least receiving one shot, we're almost at 50% right now. But the other part of the story, which is sobering to me, having worked in lower socioeconomic countries, is that there's a marked disparity worldwide in terms of vaccines efforts. So you can see here the top countries in the gray is receive at least one dose, green is receive both doses. So if you're fortunate to live in one of these countries, you certainly are benefiting. You can see here the United States here. We're certainly in the top 10. But if you look at the countries that are down here, you'll be amazed, there's a marked disparity there. And most of these countries down here are lower socioeconomic countries. And our own country that we visit, Honduras, as well as work that we've done in Guatemala, vaccine rates are less than 0.5%, which is a strike contrast. So one of the vaccines we worked on here in Kansas City was the Oxford Astrazeneca vaccine. This vaccine was developed in Oxford University. AstraZeneca subsequently bought that. And you can see that in terms of the ones in the U.S., which are Pfizer and Moderna, the most commonly used here in the U.S., really not as well used across the world. And that is the limitation of it requiring ultra low refrigeration and freezers. And so because of that, when we started our study here, we were very interested in AstraZeneca's vaccine because it only required simple refrigeration. And we knew worldwide this would be very important. And in fact, it has been. It's been used in over 165 countries. It is the #1 vaccine used worldwide. And so, as I mentioned, I was fortunate to partner with my colleague at Children's Mercy, Barbara Pahoud. We were funded by the NIH to conduct this vaccine study. We targeted to enroll almost 600 participants, and I'll tell you how we succeeded in that regard. The one thing that we did, though, we carefully, when we were planning the study, we said we have to target the disadvantaged populations. And we have to work very hard at that at the very beginning. And so we crossed all the barriers. We said we're going to work outside of the KU system as well. So I used my 2 KU campuses to do the study, and one in Wichita, but also partnered with FQHC serving downtown Kansas City, the Casey Care clinic there. Also went to Swope Health, TMC Lakewood. We partner with Dr. Steele to go out to TMC Lakewood. And then we also went to Health Partners out in Olathe, which serves primarily a Latino population. So this was a challenge, and it was possible because we actually were able to rent this medical van, and so we traveled to these distant sites. And so this is the preliminary data that was released in a press release now 2 months ago. We're still waiting for the final FDA word on the AZ vaccine. But the preliminary data from this study shows that it was 76% effective at preventing symptomatic COVID-19 infection if you measure that after the 15 days after the second dose. And importantly, it was also very effective in the elderly. At 65 years of age, 85% efficacy. And then lastly is, this is probably the most important, though it was a secondary endpoint, was in terms of severe COVID infection or hospitalizations, it was 100% effective. So in other words, if you receive the vaccine, none of those patients ended up in the hospital or having severe COVID infection. So we were fortunate through that partnership to enroll 503 participants. 21% were African American, which was exactly, we were aiming for 20% enrollment, and then 18% were Hispanic. And this was exactly what we wanted to accomplish in partnership with UMKC, with Children's Mercy, and with the FQHC clinics I mentioned. We were able to accomplish that. I can guarantee you, if we had just stayed at Rainbow Boulevard and KU, we would have not had that accomplishment. So I just want to end with a tribute to my team, coordinator team. Some of them have moved from St. Louis when I came here to KU with me. But this team has allowed us to do the studies that I am sharing with you today, and have allowed us to really enroll across these studies. You can imagine we all came here to do asthma work, and then the pandemic hit, and they had to shift gears to really addressing the COVID pandemic and participating in the COVID studies. And that's been very stressful for my team. It has really been a once-in-a-lifetime opportunity, as I tell them, but still, it's been stressful. And we're just starting now to shift back to enrolling into our asthma studies at this point. And this is my lab that has worked in conjunction with our coordinators and helped us evaluate some of the biopsies and other data that I shared with you at the end. So there is a mascot here that you may recognize, and certainly all this team together has helped me in terms of our studies that I shared with you today. But at the end, I do want to thank UMKC for helping me get there. Thank you.
Got the monster with me. This thing weighs a ton. It is my pleasure to formally present to you Dr. Mario Castro, this year's Take Wing Award. And I think everybody in this audience, everyone who's listened in, knows that he represents the type of excellence that we aspire to, not only through the School of Medicine, but as we send our graduates forward across the country and around the world. Thank you so much. So I'm glad we have a few minutes for question and answers, and I'd like to start us off, if that's okay. In the pediatric population, Black children have the highest risk of severe asthma and of death from asthma. And Dr. Bridget Jones, who's one of our assistant deans of our students and a pediatric allergist and immunologist at Children's Mercy, has noted that in the studies of these newer therapies, as you looked at enrollment, there were essentially no Black children enrolled in those studies. And so I wonder if you would have a comment about race as a risk factor for adult asthma, and whether or not you had any of those challenges in doing for these new therapies what you did so well in the COVID vaccine studies is ensuring that vulnerable populations got included.
Yeah,
So I'll let you start.
great question, and I think you're 100% right, and Bridget's right as well. As unfortunately, when these pharmaceutical studies often roll out, they enroll predominantly Caucasian, and at the end of the day, then you can say, well, it works really well in a white person, but you can't say that the same thing for minorities. And so we've been very careful in every one of our studies to enroll the population that represents the disease. And so we've done that with asthma. When we were in St. Louis, up to 40% of our participants were from minorities in our asthma studies. So at the end of the day, in like our vaccine study, when we went back to the community, we met with recently with Hispanic leaders as well as leaders from the African American community. We shared the same data I shared with you, and I said, 20% of our enrollees were from minorities, and we now know from the vaccine study, actually, the Astrazeneca vaccine, that it worked just as well if you were African American or if you were Hispanic. So that's a very important message, and I agree 100%. You have to find the patient population, and it's not easy. I can tell you, going to those different locations was not easy. Some of those locations, we had pretty high no-show rates. We just overbooked the slots in order to accomplish the mission.
That's amazing. Thank you for that. Other questions? Dr. Paula Nichols?
Yes, thank you for that wonderful talk. And I have a question. What was the biological rationale for using the thermoplasty? Was that to kill the mucus-containing cells?
All right, great question. So the biopsy studies we had shown before is that the smooth muscle around the airways actually becomes hyperplastic as well as hypertrophies. And so when we did the biopsy studies, we showed that with thermoplasty, with that thermal energy, it actually causes the smooth muscle cell to undergo apoptosis. And so that apoptosis of the smooth muscle reduces the airway smooth muscle by at 70%. And it's a long-lasting effect. Studies 2 years out after thermoplasty have shown that the smooth muscle doesn't come back. Now, it's an interesting question you ask about the goblet cell because with thermoplasty alone, the airway epithelium comes right back, and it comes right back with those mucus cells. And we believe because you haven't done anything to abrogate IL-13. And so I have a fair amount of patients, actually, I do both. I use a biologic to block T2 inflammation, and I use the thermoplasty together in those patients to treat both mechanisms. So it's not an either or. We actually sometimes have to use both to treat both components of the mechanism. We're actually launching a study this next month called Realplasty, where through a device, we're actually going to try to knock down the goblet cells with a device. We're going to do it in COPD patients first and chronic bronchitis patients, but we'll be enrolling that study here in KU here within the next month. So it's an exciting target because, a lot of patients don't want to take medications chronically. They'd rather have surgery or, one-time kind of a fix. And so, and also socioeconomically, it makes sense. Could you have surgery to correct the problem?
Can you use the thermoplasty for other pulmonary diseases? I mean, I'm not a clinician, so
Sure.
For idiopathic pulmonary fibrosis, could
Sure.
you use it for that also?
Yeah, we call it a smooth muscle treatment. And so it doesn't reverse fibrosis. It doesn't have any other indication at this point outside of severe asthma. In fact, when I select patients for thermoplasty, they have to prove to me that the smooth muscle is driving the problem. So I do a methacholine challenge in those patients, a bronchoprovocation study, which we do even in kids. they have to have very twitchy airways, because I said if your airway's not twitchy, then thermoplasty is not going to help you. So that's one of the ways we select patients for that.
Dr. Mark Nichols?
Yes, thank you for the talk on Saturday and also today.
Thank you.
Both of them. I had a question about aside from the heat shock response, which I suspect is happening. With the biologics, of course, those are probably given systemically, right? Is there any thought to try to give them more locally so that you could get either higher concentration or better efficacy in lung tissue?
Yeah, so we are trying to do that. We're starting a study that is using a nebulized form of a biologic to deliver it to the airways. Some preliminary studies that were done with an anti-IL-4 were unsuccessful. Now, it may be that the molecule is not the right molecule or not enough concentration in the airways, but that it does make a lot of sense, and potentially you could do it that way. The downside that we potentially would have in some patients that have other T2-driven disease, like I mentioned, the eczema or the sinusitis, then you're not going to be able to treat those by something like that's nebulized. So systemic therapy will still be indicated, of course, in those patients, but down the road we may have that mode of action.
I have a question. Thank you for an excellent talk.
Thank you.
Is there an association between various environmental triggers and these phenotypes that you've discussed?
Sure. Yeah, environmental picture I barely touched upon, but it's a huge issue in asthma, and it's a huge issue in the underdeveloped countries that I mentioned in our work in India with biomass combustion. So what we know about the environment is that you can modify your environment, and it will, if you have a specific sensitization to, say, cockroach, or that if you abrogate that by modifying your environment and you sustain very low levels, that you can actually improve that patient's asthma control. The problem with environmental modification or mitigation is that it's hard to sustain. So many of those households where a nice study was done on cockroach intervention showed that levels started to go back up after 6 months. And so that effect is very hard to sustain. And so, I'm very practical with my patients, and I say, if you're highly allergic to that cat and that cat's coming into your bedroom, perhaps we need to do things to minimize, that allergen exposure, and we focus on that. But as we all know, our cat lovers and our dog lovers are not going to often give those up. So, we tackle the problem where we can. And unfortunately, we have good medications. Even if they have ongoing environmental exposure, we're able to overcome that response. The one environmental exposure we can't overcome is smoke inhalation, for either biomass or from cigarette smoke. It basically takes away the efficacy of all the drugs that we have. And so improving the cooking stove, if you're in a lower resource country, and improving the external ventilation does help improve the overall health of that patient. And we think that's, when we think about the global impact of, biomass combustion alone, it is far greater than cigarette smoke. That it's estimated almost 3 billion people in the world use biomass to cook with. And so we're very interested, the World Health Organization is very interested in how, and certainly as we talk about global warming and all these other interesting aspects of why we need to reduce that dependence on biomass for cooking purposes, it's a big public health target.
And the same would apply for transportation-related emissions?
Yeah, so, what's clear is that there are certain transportation pollutants that can trigger disease. So diesel exhaust has been well studied. And so that's why most of us, or most counties, have been able to work with school districts to mitigate from school buses for children, parked in front of schools and running their engines and exposing the population to diesel exhaust. So mitigation efforts have been successful in that regard. And the other environmental pollutant that has been studied well is distance from a highway. So the farther you're away from the highway, the better, because the cars, the rubber from the cars becomes aerosolized in these particles, and it actually contributes to air pollution as well. So there's just two examples of environmental pollutants that have been mitigated. In general, when you look at over the last 30 to 40 years, environmental pollution has dramatically decreased here in the U.S. But as we now have become aware of, it's not just what happens in the U.S., right, that affects us here in the U.S. And so that's why this World Health push to try to minimize carbon emissions is so important.
Thank you.
Yes.
Thank you for the great talk, Dr. Castro. I'm a rising year 6 student. I'll be applying into otolaryngology this upcoming cycle, so I was particularly interested in your talk on chronic rhinosinusitis with nasal polyps and the use of dupilumab in that condition as well. And I've seen that some of the concerns that rhinologists have is we don't know how long to treat these patients for. Do they, once you start them, are they on this medication forever? And is that something that has been addressed in the asthma literature? And what are your thoughts on that?
Yeah, it's a great question. We've actually met together with the Otolaryngology Society and have published in that area. So the thought is if you have really bulky, grade 4 polyps, that you have to debulk them first to alleviate that patient. So like my patient I was talking about that I saw this past week. But we know with dupilumab, it decreases the polyp size by 50% at least, or greater on a visual score. And often those patients' anosmia resolves and other signs of chronic rhinosinusitis. What we know about the lasting effect is that the T2 inflammation it doesn't go away once you stop the drug. It comes back. So if you use an anti-IL-5, eosinophils come back in about 12 weeks after stopping the drug. With dupilumab, some of the markers of T2 inflammation come back around 3 to 4 months. Now, I haven't seen any study yet with chronic rhinosinusitis and seen what that lasting effect is after you stop the drug. But I imagine the process will likely come back if you stop the drug within 3 or 4 months. I think eventually where we're going to get is that you'll have longer monoclonal antibodies that will have longer half-lives, that you'll be able to get by with your patient, maybe treating them once or twice a year with a treatment that will complement the surgical approach to that disease as well.
Thank you. I want to say that your remarks on Saturday at commencement were inspiring. The talk today was so educational, and I think everyone in the audience, no matter your specialty, has learned something. We thank you for your efforts on the behalf of all the patients who have suffered through the COVID pandemic, and especially those related to your vaccination efforts. And then lastly, the international efforts that you've dedicated your life to thus far, especially with the building of a hospital that is sustainable in a country where otherwise that care would not be sustained, is really remarkable. So we're so honored to have you as our Take Wing awardee this year. And I wanted to say one more time, congratulations to you. Really great talk. Thank you so much. Anybody else who has questions and would like to greet Dr. Castro afterwards, please feel free to come forward.